Today I've been asked to speak on the topic of apraxia of speech, which is a delight for me. I speak both on apraxia in adults and in children, and see a lot of those folks at the Mayo Clinic. The one thing I like to do when I begin teaching, anywhere I go, is to tell people that I'm your colleague. I work very similar, I think, to the way you do, because at Mayo, my primary job is to be a clinician, and I see patients all day, every day. I do at least 6 evaluations a day, most of the time 1 or 2 therapy sessions. Our job at Mayo is primarily differential diagnosis of individuals with neurologic problems. But because I do research in childhood apraxia of speech, I'm always doing some therapy with those children, so I keep learning. Because the adults and children that we see really are our continuing education, aren't they? I mean, they teach us our craft. I'd like to know a little bit about the people in the audience. How many of you are still students? A few of you? I'll try not to pick on you, but you're used to that, right? I mean, you're used to people asking you questions, so I may pick on you. How many are new to the profession, maybe within 5 years of graduation? And how many have more than that, more experienced? Oh, experienced group. Because I don't speak Swedish, of course I'll have to speak in English. Everyone I've met here speaks English quite well. But if I use a term or something that's confusing to you, just raise your hand. We have time to be interactive, I think. And if you have questions, I don't mind being interrupted. I've gotten pretty good at keeping us on track so that we finish everything today. Now, how many of you had a university course just in apraxia of speech? So, a few of you. How many of you had maybe only 1 lecture in apraxia of speech? Because in the United States, oh, there's a few, 1 person, but that's not unusual even in the United States, where, you know, there's a 4-year undergrad and a 2-year master's program. Even then, sometimes apraxia of speech is put a little bit in the aphasia class. Or if the students are lucky, there's a course in motor speech disorders, which would be apraxia and all the dysarthrias. So there are a lot of speech pathologists all over the world who don't have a lot of education with respect to apraxia of speech, so I'm very happy to be talking about this today. So let me just review quickly what I will do in the next couple of hours. We'll review some basic definitions of aphasia and apraxia of speech, just so that we're all on the same page. I'll give a brief historical perspective, and the reason for that is really to illustrate how a speech diagnosis might contribute to neurologic localization and diagnosis. And that's a lot of what we do at the Mayo Clinic. The neurologist there, it's an exciting place to work because it was really the place in America where medical speech pathology started. And one of the neurologists there many, many years ago recognized that because the brain controls speech in very particular ways, that it might be a help to the neurologist to sort of weed out which neurologic systems might be involved and which are not. Brought in some Fred Darley, Dr. Darley, to be the first speech pathologist there. And the rest is history, and we'll go over some of that today. We'll then discuss more specifically apraxia of speech, especially with respect to definitions, descriptions, and some video. We'll then move toward progressive apraxia of speech. Do you see many of these folks in your practice, people with progressive apraxia of speech? They're probably out there, but it's not always recognized, and yet it can be a very important cue to neurologic pathological diagnoses, and I'll talk about why that might be. We'll review some research examining the relationship of progressive apraxia to neuropathology. And then we're going to get to the heart of the matter and spend most of our time on what do you really do in assessment and how do you interpret that assessment data so that you have a good idea not only whether apraxia is there in addition to the probable aphasia, but to what degree, with what severity. How does that help you decide what to do? How does that help you decide where to start, what approach to take, what stimuli to use? Which are all, of course, those important questions that as clinicians are the crux of what we do to help our patients. So I'll just do some basic review first with respect to aphasia and apraxia because they so often co-occur. We know that about 21% of all stroke or cerebrovascular accidents have aphasia as the presenting symptom. Aphasia and other types of communication disorders really help facilitate determining the localization, and they facilitate understanding speech and language organization in the brain. So let's go over some basic definitions to begin with. Aphasia versus the non-aphasic cognitive communication disorders, and then apraxia speech. You all got a handout, a PDF? Some are saying yes and some are saying no. I did send one, so if you don't have one and you want to follow along, they are here somewhere.
In the back.
In the back.
No? Ja, slut.
I saw some people doing this and some people just doing this. So if you want it, it's back there. So aphasia, we know, is a disorder of symbolization. That just means that there's this impaired capacity for interpreting and formulating language symbols. But usually it affects all the modalities of language, that is, understanding language, speaking, reading, and writing, versus what we know as cognitive linguistic disorders. Now, these might happen due to damage to other parts of the brain, such as the right hemisphere, or it may result in a more generalized way, which we call language of generalized intellectual impairment related to dementia, and then the language of confusion, which we often see in people with traumatic brain injury. So let's start with right hemisphere lesions. When one has a stroke in the right hemisphere, there's an identifiable group of both sensory and perceptual, as well as language or linguistic deficits that can occur, and sometimes these are very subtle. And these subtle things are confabulation, trouble staying on topic, and difficulty with inferencing. Now, those aren't specifically linguistic, but they're processes that subserve language. And if there's difficulty with these kinds of processes, then that will impair communication. The second category is that of generalized, the language of generalized intellectual impairment. And these are the kinds of cognitive language problems we see in people with different kinds of dementia. So these are deficits in cognitive functioning that subserve language, such as attention and decreased memory, disorientation, poor judgment. And if you have difficulty with focused attention, if you have difficulty with working memory, that's going to impede your ability to comprehend language, to think of what you want to say, etc. And then finally, the language of confusion. And this we see more often in traumatically brain-injured people, where you see confusion and disorientation, bizarre, confabulative, sometimes irrelevant speech, sometimes little awareness of their deficit, and most often you see disorganization in their speech. But that disorganization just reflects the disorganized thinking. So those three kinds of cognitive linguistic impairment we differentiate from aphasia, which is specifically language impairment. So where does apraxia of speech fit into all this? Well, first of all, I think when we think about apraxia of speech, we're talking about a whole different entity. And that's because apraxia of speech is a motor speech disorder versus aphasia, which is linguistic, and versus those other cognitive linguistic impairments in communication. You know, it's really more correct to say that apraxia of speech is a sensory motor disorder. And this will become clearer throughout the talk. But because I'm going to talk a little more about what do we mean by motor planning and motor programming. And I'll talk about the fact that a lot of what goes into motor planning and programming is the sensory, especially proprioceptive, kinesthetic sensory information that is constantly fed to the cerebellum and the basal ganglia and those internal and interactive circuits, which all gets fed to the motor planning areas of the brain. And that is a big part of the problem of apraxia of speech. So we say that it's a sensory motor disorder of primarily articulation and prosody. We know that apraxia of speech is characterized by difficulty with the capacity to plan, to program movements for volitional speech production. And in the United States, this is an important thing to differentiate because for many years, and I'll talk about this, there was confusion about apraxia of speech because people would think that it was the inability to sequence sounds. But the reality is, when we're talking about apraxia of speech, and this is very important to planning and implementing treatment, the essence of the impairment in apraxia of speech is not the inability to sequence sounds, it's the inability to plan and produce accurate movement gestures, movement transitions that result in the acoustic output, reflecting sequences of sounds. So see, the focus in assessment, the focus in treatment is not the sounds, it's the movement. And that changes everything with respect to how we interpret our assessment data, with respect to how we choose targets for treatment, with respect to how we facilitate and shape movement during treatment. It affects what we provide feedback on and how, and it affects our outcome measures. Now, although apraxia of speech usually co-occurs with aphasia, the two usually come together, the nature and the deficit of apraxia of speech is motor planning and programming, the accuracy of the movement, not the linguistic nature of the problem. So we say that apraxia of speech is a motor speech disorder. I keep playing with this because my head must be awfully small because it keeps hitting my collar and I'm afraid I'm going to knock it off. Apraxia of speech is a motor speech disorder. And as I said, we like to use the term sensory motor to bring in the fact that that tactile proprioceptive input is essential. Apraxia of speech results from the difficulty with planning and programming movements for volitional speech production. And although it occurs with aphasia, it is separate. And if apraxia of speech occurs with the aphasia, our challenge, our job as speech pathologists, is to determine to what degree does that happen. Is the apraxia worse than the aphasia? Which is getting in the way more of that person's ability to communicate his needs and wants? And then we plan therapy appropriately. So we're going to consider these disorders now, aphasia and apraxia of speech, in terms of three things. First, a basic model of speech-language processing. You know, we always learn these in school. There's lots of different models and ways to explain. This is a very, very basic one that I often use with families. When I'm in that hospital room and a gentleman is in the bed who's got aphasia and apraxia of speech and the wife is asking me, what's happening, what's going on? This is one way to explain that to her. Then we'll discuss it in terms of the neuroanatomic localization and then finally in terms of the behavioral considerations. So starting with a processing model, you know, when we go to say something, what does it start with? It starts with ideation, with this intent to communicate. So if the patient lying in that bed is thirsty and wants some water, and he doesn't have significant dysphagia, so they don't have the little sign, nothing by mouth. Do you do much dysphagia here? Some do. I hear that you're doing more of that. In the United States, it's gotten to the point now where that's about 3/4 of most of the hospital practices. So it's different from place to place. So they have the intent to ask for water. Now, they can do that in a number of ways. They can point, they can use a gesture or sign. But we're here to talk about apraxia of speech, so we're going to consider speech or talking. And if that person wants to say that, they have to move from this cognitive intent to communicate to some way to symbolize that verbally, which is language. So then they have to retrieve words and find the phonology and all of that. But at the end of the day, what they have to do is make noise, don't they? They have to make noise so that the listener can hear what they're saying. So to make noise, what do? We move. We move respiratory muscles, we move laryngeal muscles, we build subglottal air pressure, we change the shape of the vocal tract, and then we constrict the moving air streams to make noise. That's what we do when we talk. But makes no sense. It was sort of like, I bet this speech was really good because people were laughing and interested, but I felt like a child in kindergarten who has a very, very severe language impairment because I didn't know what was going on. So for me, that made no sense. I'm sure it was very good, but I couldn't understand it. So it's the same thing. You don't understand it. These movements can't be haphazard. They can't be random. Or the person listening to that acoustic signal won't be able to understand. So these movements have to be made in a very particular way so that the vocal tract shape is very particular and that constriction of the airstream happens in just very particular ways so that that acoustic output is meaningful. Well, in order for those movements to happen so that the vocal tract shape and constriction all happens at the right time, motor planning and programming has to happen. So let's look at it in a little more detail. Again, we said ideation is the communicative intent, and that is a cognitive process. But if we're going to speak, then we have to symbolize with a word or a series of words. And that means retrieving the word, doing the phonologic mapping for the word, the syntactic framing if we're going to use more than one word, and at this point it's still all linguistic. Now, when we have a problem here with ideation, we're talking about people perhaps with significant dementia, significant TBI, maybe autism if we're talking about a child population, where we would begin working with that child to help them develop even a pointing response or the intent for meaningful communication. When the problem is primarily here with the symbolization of the linguistic problem, then we say it is aphasia. This is what we're talking about, though, with apraxia of speech. The ability to plan movement, to specify these movement parameters. So when we talk about motor planning and programming, we're really talking about specifying the range of motion, the strength of the motion, the speed of the motion, the direction of the motion, the degree of muscle contraction. So the brain has to send these messages to tell the jaw to move just 2 centimeters, and at the same time, the tongue better come forward 1.5 millimeters, go up 2 millimeters, and tighten a little bit. And at the same time, all of these messages go to the intercostals, to the diaphragm, so that certain amount of subglottal air pressure gets built up to blow the vocal folds open, right? Put them in periodic vibration. But then we have the vocal tract making very particular and yet subtle changes so that the vowel sounds change. And if it's off just a little bit, like in my Guten Morgen, it'll sound funny. Now, people with apraxia of speech, because they have trouble planning with the degree of specificity they need to, will have vowel distortions. Because that vocal tract shape is just a little bit off. And so will the children. We'll hear that this afternoon. Then, finally, we have the acoustic output, which results from the actual generation of movement. After it's been planned and the motor strip sends the messages down to the brain stem, lower motor neuron fibers go out and cause the muscles to contract so that that jaw does move in the right direction with just the right number of millimeters at just the right speed. And it involves all these processes of respiration, phonation, resonance, and articulation. If there's a problem at this level, then we call the speech disorder dysarthria. And that we won't be talking about today. Now, if we're not going to take a lot of time with this today because we only have a couple hours and I want to spend most of our time clinically talking about assessment. I think you guys probably agree. But I did put this in the handout so that you have an idea of a little more in-depth model of the kinds of things we think about when we model motor planning and programming. So we have sensory motor planning up here, which is coming to the spatial configuration for the acoustic goal and planning the articulatory movement dynamics. But then we get down to the more specification of movement. So the positioning dynamics, the force function, the relationship, timing and spatial relationship of the interstructural components, the timing relations, etc. So we can, I'll let you look at that, and if you have questions, you can ask me later. And then now we're going to talk about it with respect to neuroanatomic localization, and just make a few general comments. We know that the left hemisphere is dominant in about 95% of right-handers and about 70% of left-handers. We know that some people have mixed-handedness and that some people are right hemisphere dominant for language. We know that in aphasia, the specific cortical areas that are likely to be involved are the left temporal parietal area, or Wernicke's area, or the posterior inferior left frontal convolution and or insula, which, or we usually say Broca's area. And in that case, we often get not just aphasia, but also apraxia of speech. Now, I've added, we turn in these handouts way ahead. And I'm always thinking about it and going over it. And I've added a few slides now for illustration. So you have all the information. These are just going to be mostly pictures. This is your left hemisphere. So what we're talking about here in terms of lesion location, it's usually on the lateral surface here versus more medial. And this is the temporal parietal area, or Wernicke's area. Sometimes we call that the posterior aphasias, versus this frontal area here, Broca's area, the posterior part of the frontal lobe and inferior part of the frontal lobe. This big fissure here, the Sylvian fissure, is the kind of demarcation, and we say that these parasylvian areas are the ones most likely involved in aphasia. So if we look at it this way, let's see, we're talking about areas 44, 45, Broca's area, as well as this auditory association here up into the parietal lobe, which is Wernicke's area. Now, interestingly, subcortical structures are also often involved in aphasia. This includes the thalamus and certain components of the basal ganglia. Lesions here can also result in aphasia and/or apraxia of speech. But because the internal circuitry of these mechanisms are very, very complicated, we don't understand the exact roles that they play that result in an aphasia. So when we talk about subcortical areas, here's a medial view of the brain. You have the cortex, corpus callosum. We're talking about this area right here, above the brainstem and cerebellum, right here, the core of the brain. If we look at it a little deeper, we see the basal ganglia here. Here's the internal capsule of brainstem. And if we go even deeper, we see the thalamus right here. So these are the areas that also can be involved that sometimes result in aphasia and even in apraxia of speech. Now, if we look more specifically at the vascular perspective, we know that if the blood supply is interrupted, resulting in aphasia and apraxia of speech, it's usually going to be part of the distribution of the left middle cerebral artery, the parasylvian area that I just talked about. But there are another small group of arteries called the striate arteries that are a common area for stroke, resulting in aphasia and apraxia of speech. And that are these areas right here. So here's the left posterior part of the frontal lobe. Here we have one aspect of the middle cerebral artery. And these small little arteries coming off here are called the striate arteries. And they're a frequent site of stroke, resulting in aphasia and apraxia of speech. This demonstration also shows these very small lacunar strokes that can often happen, which are just little strokes that happen at the most distal or very small branches of arteries, causing little areas of infarct, usually deep in the parenchyma. We're going to come back to a little more neuroanatomy in a little while. What I want to do now is to go into more specifics with respect to definitions of aphasia versus apraxia of speech. We know that aphasia is a disorder of symbolization. It's linguistic. It's impaired capacity for interpretation as well as formulation of language symbols. It affects all modalities: listening, talking, reading, and writing. In aphasia, the language impairment is greater than the impairment of other cognitive function. When we use the term aphasia, we're implicating that it is not due to sensory or motor impairment, although it is often accompanied by both. But there's utility, as you know, in differentiating these terms, because what we do to treat them is very different. I can't tell you how often it's happened where I will get a patient who's perhaps 2 or 3 years post-stroke who might come to Mayo to see if there's anything else that can be done. And when I look at their early records, I see that they were only given language treatment. But they had a severe apraxia of speech. And they wondered why they hadn't made any improvement. And I think the reason is that if the primary problem is motor planning, and we treat language, we're not addressing the primary deficit. And that will result in much less improvement. So there's utility in differentiating these terms, especially when it comes to our diagnosis, what we do to come to that differential diagnosis, the interpretation of that assessment data. Now, traditionally, researchers and clinicians have categorized aphasia into different types. These different types then correlate with anatomical localization. The trouble is, only about 30% of aphasic individuals fit into these categories. So at Mayo, one part of my job is to teach the neurology residents, and we do that by lectures, but they also do rotations with us. They'll just stay with us for 2 weeks and see all the patients with us, and we sort of teach that way. And on their boards, to be a neurologist, they have to pass these boards. They need to know all these different classifications. And so we teach them, and then we say, but forget it in real life, because it just doesn't happen. There's some predictability in terms of speech and language function and their association with damage to certain areas of the brain. But there are a lot of problems with categorization. Different people use different terminology. But mostly it's hard because most patients don't fit into one category. The basic dichotomy, though, is anterior. So these are aphasics who fit into categories that we call non-fluent, Broca's, or expressive aphasia, versus the posterior lesions, that is the Wernicke's area, which are more fluent. Sometimes it's called Wernicke's aphasia or receptive aphasia, depending on, at least in the United States, depending what part of the country you're in, they may use different terms. These are the aphasia classifications that we teach our residents because it's on their boards, but clinically we don't use them. Are you still using these here? Not so much? They're very nice and they're all set out, but in real life, very few patients fit neatly into any one of these categories. So I want to take a few minutes here to do a little history, to talk about when an observation of speech characteristics first led to the notion regarding neurologic diagnosis and even neurologic localization. I mean, I think it's pretty cool that we're in a profession that's so important because it was really a speech problem that led to this whole concept of neurobehavioral correlates, that certain parts of the brain were responsible for very predictable characteristics. So this is Paul Broca. Do you all get this in school already? Good. Well, in 1862, he did something very important. He demonstrated that the brain lesion of one of his patients who had suffered from, I can't speak French either, aphemia, later renamed aphasia by Trousseau, he had found this gentleman who was speechless. He also had hemiparesis. And at autopsy, Broca found a lesion in the left frontal lobe. Then, soon after that, he did an autopsy on a gentleman who also had suddenly lost his speech, and it showed a lesion in the same place. So Broca determined that this area of the brain must be responsible for spoken language. And in doing that, he really contributed this concept of functional localization. Because of these observations he made of people with brain damage, and he developed this concept of left hemisphere dominance for speech. And he concluded that the posterior part of the third frontal convolution was responsible for articulated speech. I think that gets to be very important later. So that's the area that he's talking about, Broca's area. And he had great foresight because he preserved these brains. Later, when high-resolution MRI was available, and they had these brains, the MRI showed that the lesions really extended a lot deeper than Broca was able to see, and suggested that other areas besides Broca's area might really be contributing to speech. But Broca's study of the localization of speech function arguably served to really launch exploration into functional organization of the brain that cognitive neuroscientists, neuropsychologists, speech pathologists all study today. Now, we know a lot more today about the complexity of functional localization. For example, we know about association tracts resulting in large networks of brain regions. And in fact, nowadays, we don't even talk so much about particular areas of the brain. We talk in terms of network, the different networks involved. I just went to a talk at Mayo a few days ago where the whole thing was on the default network and how some of these networks are responsible for inhibition and how important that is, and that so much of the brain in these networks actually inhibit. And we keep learning more and more. But Broca did much to set the stage for the fields of speech pathology and neurolinguistics and neuropsychology, cognitive neuroscience, etc. Now, as we move to more modern times and the concept of motor speech disorders, which is what we're here to talk about today, I was a professor at the University of Washington. I worked about 9 years before I went back for my doctorate. So I was a speech pathologist with my master's degree working, and then I decided I wanted to know more, and I thought, if I get a doctorate, I'll know everything. And I wanted to know everything. So I left California and I moved all the way to Madison, Wisconsin, because everybody doing all the research in apraxia of speech at the time was there, and I didn't know a soul. And I was a single parent and I had a 4-year-old daughter. When I think about it now, it was absolutely crazy. But I really thought that if I did all this, I would know everything. Well, when you do a doctorate, for those of you that have done it, you know this is true, you leave there knowing you don't know anything. And it's quite sad, but you learn how to think, which gives you hope that you will keep learning. But then I taught college for a number of years, quite a few years. And while I was there teaching away, and even as a student, and even as a young speech pathologist, I had heard about the Mayo Clinic. And this idea of medical speech pathology, because Mayo is really where medical speech pathology started in the United States. And the Mayo Clinic, Darley, Aronson, and Brown, you may read those books. And later, Joe Duffy, who is my colleague now, wrote these seminal texts in motor speech disorders. So I was at the University of Washington, and Dr. Duffy called me one day and asked if I would consider taking Dr. Aronson's job because he was retiring. And I'm thinking, you gotta be kidding me, Mayo Clinic? Oh, it was very exciting. But I had it good, you know, I was in Seattle. Seattle, have you been to Seattle? Some nods? Oh, it's beautiful. It rains all the time, but it's, when the sun's out, those few days when the sun's out, it's glorious and beautiful, and you've got mountains and water, it's gorgeous. And I had tenure, and so I was safe. I had doctoral students, I had a great lab, and I thought, I'm not moving to Rochester, Minnesota. It's cold there. And Rochester is this little town. And it's a long story that I won't go into why the big fancy Mayo Clinic started there, but it's this little farm town, about 100,000 people, but in the middle there are like 6, 8 square blocks of these huge, tall university buildings, medical school, clinics, research buildings, and then all the big hotels, because so many people come to Mayo from around the country. So you've got this farm town, and then this huge kind of mini city in the middle. It's the oddest place you would ever be. But I decided to just go look. And I couldn't believe how amazing it was. And it gave me the opportunity to go back to full-time clinical work. And that's why I say I do what you do. My first patient's at 8 o'clock. I never finished dictating my final report until about 6:30. It's a long day every day. And then when I prepare talks like this, it's on the weekend. Or when I try to write an article, it's on the weekend. So people, my family thinks I'm crazy, but I'm not. Because this isn't just my job. And I bet many of you are the same way. What we do to help people communicate, aren't we lucky we get to do this? It's so exciting. So I ended up at the Mayo Clinic because, and was very happy to, because the Mayo Clinic, Department of Neurology, really has contributed a lot to the study and clinical management of motor speech disorders. In fact, the work of Fred Darley, Arnie Aronson, and Joe Brown, that Darley, Aronson, and Brown, the first book on motor speech disorders, really led a paradigmatic shift in the science and clinical management of motor speech disorders. I think that's unequivocal. So what are these motor speech disorders as they define them, as we still define them today? Well, they're a group of speech disorders that result from damage to one or more central or peripheral neurologic systems that involve the planning, programming, or neuromuscular control and execution of speech. Typically, they're divided into apraxia of speech, which is motor planning and programming, or dysarthria, which is the actual execution of the movement. Now, although Mayo is well known and regarded for clinical and research advances in the area of dysarthria, it's also the place where the modern concept of apraxia of speech originated. Fred Darley was actually the person who proposed and developed the modern concept of apraxia of speech. Way back in 1968, he posited the use of this term to discriminate the language impairment that we see in aphasia from and the movement disorders we see in dysarthria, with this third category, which he believed resulted from impairment in planning and programming movement gestures. Now, years before that, neurologists had been talking about problems with limb praxis. Ideational apraxia, construction apraxia, but basically it was limb praxis. Show me how you point to the door, and they might go. You could say something that simple, point to the door. They know what you want them to do, and they can't plan and specify the movement to do that, or to give the peace sign, or to flip a quarter. Show me how you brush your teeth. They may know exactly what you mean, but they would do this. They can't do it. So he recognized that there was a similar kind of thing that was happening in speech production. Now, he posited this, some people bought it, but debate kind of raged for 20 years as to whether there really was this category of impairment separate from aphasia and dysarthria. But there was this huge body of both perceptual, acoustic, as well as physiologic research that demonstrated the validity for this category. And very few people will refute it today. Few, especially in the area of progressive apraxia, which we're going to get to in a minute. So while the original motivation was for specifying the taxonomy, the original motivation was really to point to appropriate treatment methods. This category has recently been shown to be associated not just with specific neurologic diagnosis, but also with specific pathology. Now this is good for us, because if we're the profession that's making this differential diagnosis, and this differential diagnosis is now pointing to a specific pathology, that's very helpful to neurologists, and it's good for our job security. Now, the original work in apraxia of speech focused on acquired apraxia, usually due to stroke, sometimes tumors, brain injury, etc. And so we're going to talk about that for a few minutes, and then we're going to get into the progressive apraxia. So for acquired apraxia of speech, we know the etiology most frequently is stroke. We know that it's typically, but not always, posterior, inferior, left frontal lobe, interinsular, but we know that it may involve the subcortical structures. If we look at the vascular perspective, like we've talked about for aphasia, it's the same. This left middle cerebral artery, often the striate arteries. And we often use, I guess you guys probably do too, when I'm explaining to a family what's really happened, I will show them a picture like this and say, well, stroke is just when there's a blood clot or some thickening of the arterial wall that causes a thrombus or a clot, and so blood can't get through a more distal artery, and the areas around that, the brain area around that, doesn't get oxygen, and so it dies, and we call that an area of infarction. And when we look at the blood supply to the brain, and we see this middle cerebral artery here, and we look at the lack of blood flow, we can actually see where an area of infarct would be. If you look at this little diagram I draw, I can't draw, so excuse this, but you get the idea. If we're looking at these different areas of the middle cerebral artery, and we have a clot here at this inferior division, then you'll have perhaps a Wernicke's aphasia in this part of the temporal lobe. If you look at it from a coronal section, it would be down here, affected. And then you would have one kind of aphasia, which is more fluent, and probably you would not have an apraxia of speech. Here, where you have the more proximal, larger part of the middle cerebral artery infarcted, you would get a global aphasia, including apraxia of speech. So it really depends where, what division of the middle cerebral artery you have this occlusion that results in a certain area of the brain being infarcted, and therefore a certain kind of communication disorder. And this is just a picture of a brain that's had a stroke showing the intraparenchymal hemorrhage. Now, acquired apraxia of speech can also occur with traumatic brain injury or neurosurgical events related to tumor or AVMs or subarachnoid hemorrhage. And apraxia of speech can also result from degenerative disease. And when that happens, we call it a progressive apraxia of speech. And this differential diagnosis is very important because it can lead the neurologist in the correct direction toward disease. And this will be clear in just a minute as to why that might be true. Let's go back though and take an example of one of these, and I'm going to use this neurosurgical result of a tumor. I saw a 29-year-old male who was perfectly normal until he started having seizures and increasing headache at about early age of 29. The MRI showed a large, infiltrating left frontal mass with mild mass effect. Now again, I have a few slides that aren't on your handout at this point just to illustrate what we're talking about. The biopsy revealed a left frontal parietal oligodendroglioma, so that's not so bad. That's not like a glioblastoma where the prognosis is very poor. The prognosis for this is better. He underwent chemotherapy and had no language or motor deficits. But then he had to undergo a neurosurgical resection. This is just the MRI showing. On MRIs, you're looking at the person as if they're laying in the machine. So this is the left, this is the right. So you see this large tumor here. So following, I saw him in the hospital post-surgery. He had severe apraxia of speech, apraxia for phonation, aphasia, a mild unilateral upper motor neuron dysarthria, left gaze preference, right facial weakness, and a right hemiparesis. So he went from being pretty normal to having all of these problems, and the apraxia was the worst. 6 weeks post-surgery, he came in for reevaluation, and he had only a mild to moderate apraxia, mild to moderate aphasia, moderate verbal apraxia, and was referred for ongoing therapy at home. He still had a little of upper extremity weakness. I had one more slide I took out. So I got to see this man recently, and he's now about 1.5 years out, and he has only a mild apraxia of speech. His aphasia is pretty much resolved. He has some mild vowel distortions. He has some mild sound distortions, a few voicing errors, things we'll go over in a minute. And I think that had we seen him 20 years ago and treated only language, that he would not have had such a good recovery. But because we focused using a motor approach to treating the movement impairment, he has done very, very well. So we've said that apraxia of speech can occur with all these things, but what is it? What is apraxia of speech? Let's go into that in a little more detail. We know that it's a neurologic speech disorder, that it's characterized by difficulty with sequential ordering of movements. Again, that's the important part because, at least in the United States, people get confused and think it's ordering sounds. But it's ordering or producing the accurate gesture of movement. Because movements don't occur in isolation, do they? We don't say, I should do it in Swedish, but I can't. Say cat. How do you say cat in Swedish?
Cat.
Cat? Seriously? I'm very lucky. Cat. We say cat. You go cat. See that little bit of vocal tract shape? Now see, I sound a little apraxic to you, I'm sure, because we don't have that exact vowel in English phonologies. And my vocal tract shape is just a little bit off. But we don't say k, at, do we? The movement is one sequential gesture of movement. Let me do something more visual. Do you say mom for mother? Mom? Mama? That'll work. Look at the difference between, well, no, let me do it differently. Let's say, I want to say me. Watch the movement. Me. Now watch the movement for what the cow says. I bet that's the same. Moo. They're both the M phoneme, but the movements don't even start in the same place. essential for when you're interpreting assessment data and also organizing treatment. Because the focus is not on the sound. The focus is on the movement gesture. And that changes everything. In acquired apraxia, the language is not impaired if we're using the term apraxia. Now we know, though, that it often co-occurs with aphasia, but we want to differentiate those terms. They coexist. In apraxia of speech, there's no muscle weakness unless the patient also has, what? Where's the students? Unless they also have, well, you were right. You have very smart students, unless they also have dysarthria. So what are the symptoms? Well, they're groping for articulatory posture, sort of like I do when I try to say Swedish words. I want to get the vocal tract shape right to get the vowel that I know I don't have a prayer of saying right, but I try. Good morning. So I'm groping a little bit. Slower rate, halting, effortful sequences of phonemes, articulatory errors, but especially distorted substitutions, inconsistency over repeated trials, longer vowel and word durations, automatic speech, meaning things that are very, very practiced are easier. So we often, if we have someone with very little speech output, we might have them try to count with us. And if you get them counting, 1, 2, 3, it might take a number of trials. But that rote, well-practiced task, often they can do. If they can't do that, then singing a very familiar song can help. They're aware of their errors. They have dysprosody, so hesitations, starting and stopping, starting over again, as well as difficulty with lexical stress. So let's take a look at a few people with apraxia of speech. This is someone with a very severe apraxia. Uh-oh, where'd he go? It's here. This was working just before we started. We may have to get him back. We had this problem before the talk started. Maybe you can do this. Oops, that's my glasses. Does that help at all? Look at her groping. She knows what she wants to say, and you see her groping around. That shows when I have her do something more automatic, she can do much better. But if I had said, how many is this, should be again, even though she knows the answer. Okay, let's look at a gentleman with more, let's look at a gentleman with a more mild. This is kind of a prototypical person with Broca's aphasia and apraxia of speech.
Turn it around, Tim. Turn it around so you can look at it.
Okay. Lady is watching her dishes.
Can you, when I hold this up, can you hear?
Ready to open. And this boy
in this gentleman, you hear all the aspects of Broca's aphasia. You hear telegraphic speech, some word finding difficulties, some phonemic paraphasias. What I want you to think about, and soon we have to take a break so she can change her video. You're going to have to let me know when that hour's up. We'll take a very short break and then we'll come back. And when we really get into the assessment task, I'm going to talk about how do we differentiate an aphasic, phonemic substitution from the phonetic errors that a person with apraxia will make. So I want you to start thinking about that as you listen to this tape because he's got both. And it's hard. This is hard. I'm going to give you some cues later as to what might help you do that. But what I want you to do is try to think about which of the errors you're hearing are evidence for apraxia of speech. Can you hear the sound additions? I know it's hard when I hold this up. You get some of the hum from that computer. Hopefully in the break they'll fix this. You hear extra sounds sometimes. The extra schwa or an extra, like drive. He almost said driving instead of drying, but the V was quite distorted. It's probably harder to hear this in another language as well.
No, it's true. Yeah.
Okay, now let's look at the gentleman that we're going to talk more about later. But he's a good example of apraxia of speech as well.
When you first started having trouble with your speech?
4 years ago.
Now, what was the first thing you noticed?
Firstly, I noticed I was training. I was slurring the words.
You were slurring the words?
Yeah.
So here you see the trial and error behavior. He starts, he realizes he's making an error, he tries again. He's got a little groping. You hear sound distortions where he's substituting some sounds, but mostly they're distorted. And that's just because in motor planning, you have to get the vocal tract shape and the constriction of the air at just the right time and in just exactly the right place. And if you're just a millimeter or a millisecond off, the listener will hear a distortion.
Mm-hmm. All right. And has it gotten worse over time?
Yes.
What other kind of difficulties are you having?
Right hand doesn't work. I have a problem touching my nose.
Touching, so it's distorting the ch. Do you have ch in Swedish? No. No? Well, we have ch. And he's sort of distorting it, so it's more of a ch. Let's listen to him saying some sentences.
At the zoo.
We saw animals at the zoo.
Right.
So there you hear some segmentation, animals, instead of animals. And you hear equal stress rather than the normal prosody. You hear more segmentation, equal stress.
My physician wrote out a prescription.
My physician brought out the
So that's phonetically very difficult. And he has his vocal tract shape off in almost the entire word there. We're going to watch more of these later. But I wanted you to get us just a, okay, let's see if I can do this. Feel a little bit like Madonna. First I felt like I was going to, did I do it right? Is it time? Okay. First I felt like I was going to be preaching and I was going to watch so I didn't start expounding on apraxia of speech and you must do this.